We need to differentiate between diseases like osteoarthritis and rheumatoid arthritis. And rheumatoid arthritis is a disease where the immune system sort of went haywire and started to secrete different inflammatory cytokines like interleukin-1 and tumor necrosis factor. And these generally are needed for health, but when the body starts secreting too much, you get autoimmune disease, which is what rheumatoid arthritis is. In osteoarthritis, it's not exactly like that. You get an inflammatory process that's thought to be from use or wear and tear. So it's joints rubbing against each other, causing an inflammatory process. That's osteoarthritis. And in osteoarthritis, we can get fantastic results by sticking with that first corticosteroid anti-inflammatory pathway that we learned from Foundations, which is that low frequency for 20 minutes or more. So this chart is comparing the difference between rheumatoid arthritis and osteoarthritis. I said in osteoarthritis, over here in the blue or green, you can think of that as an overuse or wear and tear. So somebody's jogging and they've been jogging for 40 years and the cartilage has worn away to nothing, and now you have knee joints rubbing, causing friction, and that's starting an inflammatory process. That's what we call osteoarthritis. In the red here, you have rheumatoid arthritis, and it's thought that rheumatoid arthritis might have been stimulated by a superbug. In other words, streptococcus is one of them. So somebody could get a streptococcal infection when they're young, and then the immune system didn't fully fix it, or maybe it got interrupted by some sort of antibiotic, and that turned the streptococcus into a superbug that kind of remains hidden but still triggers the person's immune system to attack itself. So in rheumatoid arthritis, you actually have too much tumor necrosis factor and too much immune system attacking joint space. So in rheumatoid arthritis, the patients will feel pain worse in the morning, and that's because overnight their immune system was attacking their joint space and all the crud built up in the joint space. And joints could be, like vertebral joints, SI joint. It doesn't have to be hands. And so the crud built up overnight, and when they stand up in the morning out of bed, they're in a lot of pain, and then they start moving around, and that gets all that crud out, and then they feel better for the day. That's like the rheumatoid pattern. It's not only rheumatoid arthritis, it's all the diseases, all the autoimmune diseases that have to deal with tumor necrosis factor and interleukin-1. So when we go over the protocols today and tomorrow, we're going to divide sort of into one group, which includes rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis. They're put into groups based upon what inflammatory cytokine we want to influence, or what inflammatory cytokine is the problem for that patient. But we're using rheumatoid arthritis as like our, what do you call it? I'm short on words. Use prototype. Thank you. That's why I was looking at you. I knew you had the word. Because if we can fix rheumatoid arthritis, then we automatically can fix 10 other diseases that have the same inflammatory process. And multiple sclerosis is a different group of diseases, which we're also going to go over tomorrow. Oh yeah, rheumatoid arthritis, I didn't know this until I started studying it. Rheumatoid arthritis is no joke. It needs to be treated. If you don't treat it, if the person gets no treatment, it could kill the person because you have the immune system attacking different structures. It starts at the joints, but it could easily go to the lungs, for example. So rheumatoid arthritis, I don't care if they get Western medicine or come see you, they definitely need to get treatment. They can't just poo-poo it, oh, it's just a little bit of rheumatoid arthritis. It's a serious disease. And without treatment, the disease process just keeps getting more and more severe. The immune system just keeps releasing more and more tumor necrosis factor. This is back to the osteoarthritis treatment. You've seen this slide from the foundations class, but you can use this slide as a prototype for any of your glucocorticoid or cortisol anti-inflammatory treatments. So in this slide you can see it's so simple. Like if somebody has stomach channel pain on the knee, you can usually get away with these 2 points here, the knee eyes, and simply by setting a low frequency like 1 to 4 hertz for more than 20 minutes, you're going to get a strong cortisol anti-inflammatory effect directly on that knee.
So 1 to 4 hertz?
Yeah.
20 plus minutes?
Yes.
Okay.
Usually 21 minutes or so. So, but you can use this now. And I'm talking about osteoarthritis or some inflammatory, any inflammation that's not related to autoimmune or immune system. You can use this to map out the elbow. You can use it to map out any pain and inflammation, right? Because that same low frequency gets the endorphin effect. So although I posted the knee, you can use this on any part of the body as long as it's not autoimmune. Autoimmune will get better results with the upcoming protocols. Yeah. If I just did knee eyes, the effect would spread around the whole knee, but maybe the knee eyes would get the most of the effect in that example. And then don't forget, you can see the dermatomes it's on too. So we're influencing, just by doing knee eyes, we're still influencing L4 and L5 nerves, which is pretty cool. So this is why, one of the reasons why you can get rid of L4, L5 back pain from knee eyes, because you're influencing the dermatomes that feed that. That's what the advanced class is. We go over dermatomes, myotomes, sclerotomes. It's a spinal-based neuro class, basically. The chronic protocol I listed down here. Why not rush circulation to the area first in the first 10 minutes and then go to the low frequency? But this is old news to you guys, right? From foundations class. So chronic and cold, first rush circulation there using 150, then switch to the low frequency for another 10 to 20 minutes. But acute, it's already possibly too inflamed, so why not just do the low frequency for 20 minutes and don't bother rushing circulation there? And this is examples that I was talking to you about super antigens. I mentioned streptococcal infections, but here I listed 2 others. One is staphylococcal enterotoxins. So you have these bugs that release toxins, and it's actually the toxins that trigger your body to get into an autoimmune sort of condition. So you could have an infection, like I said, when you were a kid, and that somehow triggered an immune response that may show up 10 years later, like an autoimmune disorder. So this is demonstrating the systemic inflammatory response that usually happens. Typically when you get an injury or even an infection, what's supposed to happen is you secrete these cytokines to alert the immune system. Interleukin 1, interleukin 6, and tumor necrosis factor are big ones. They're the key players. And they're kind of pyogenic, so they can cause fever for sure. They're supposed to do their thing and then go away, but they don't always go away in time. They can linger. And I'm going to show you how to trigger the body to stop secreting them or turn down the amount that is being secreted. And this is like very exciting stuff to be able to do that for your patient. So this is the pathway. We're now going into the left cervical vagal pathway. That's what this chart is demonstrating. This comes from the research that's been done with that vagal nerve stim implant, which is getting pretty big. And basically they stimulate here. For us it's stomach 9, but it's the left cervical vagus branch, which goes into this celiac ganglion, which is a huge ganglion that we're going to be influencing. And this ganglion feeds into the spleen, and the spleen is where the tumor necrosis factor is being secreted. So we're going to be able to turn that off and help our patients like that. So if you notice here, the preganglionic is like I told you. It's acetylcholine. Once it synapses at the celiac ganglion starts releasing norepinephrine. It's the norepinephrine on this beta receptor in the spleen that triggers it to turn off or turn down tumor necrosis factor. There's a lot of immune system modifying drugs. So if somebody has rheumatoid arthritis, they would use a prescription. Methotrexate's one of them, although that one works on folate and preventing the production of folate, which is needed for cellular regeneration. The one I'm more interested in for rheumatoid arthritis is etanercept. And things like etanercept, which block the production of tumor necrosis factor. Our treatment is superior, shown to be superior when they compared electric vagal nerve stim to the drugs. And one reason why it's superior is we're not blocking anything. We're only modulating and reducing the amount of tumor necrosis factor that the spleen is producing. So when people take something like a drug that blocks the tumor necrosis factor, they're now at risk for other infections. Like let's say they had tuberculosis that can go latent for a whole lifetime. But as soon as they start on this particular drug, there's no more tumor necrosis factor, and now the tuberculosis can come alive and actually kill them. For us, at that same situation, we're just attenuating the tumor necrosis factor production, reducing it, downregulating it, so that it's not blocking it. There's still some circulating tumor necrosis factor. We're downregulating it enough to get fantastic results, better than the meds. And actually in the study that I was telling you about with the implant where they were stimulating once a day, that eliminated rheumatoid arthritis altogether. So it's really good results. Also, if we're seeing the patient, let's say 3 times a week, there's still the period in between treatments where if their body needs a rush of tumor necrosis factor, it can do it. So that's why our treatment to reduce tumor necrosis factor in autoimmune disease is way superior to the prescription drugs. And that's not my opinion. That's coming from the recent research where they compared vagal nerve stimulation to these prescription drugs. And I cited quite a few references at the back if you wanted to go dig up the research.
But they were doing one every day, right?
They were doing every day for 60 seconds.
Yeah, but
60-second stimulation.
So the patient's going to come to us every day?
So our protocols are modified because one, we're going to be treating longer than 60 seconds. And two, we can get fantastic results with 3 times a week is what I recommend for the first month. That everyday thing, they did every day for 42 days and then stopped altogether, and the results lasted full 2 weeks. So we kind of have to modify the protocols because they can't really realistically come to us every day. However, the protocols that I give you are pretty good. It works in most of the people, and it's good enough to see somebody 3 times a week for the first month or 2 and then start reducing. So I told you it's really the celiac plexus. Here's a better picture. Celiac plexus. So from the left vagus nerve directly goes to the celiac plexus. The celiac plexus directly goes to the spleen, which is our target for this particular treatment. And it's really cool too when we start getting into the ear tomorrow. We have a section on ear pharmacology. You can influence the celiac plexus from an ear point, which is awesome. But good thing we don't have to needle the celiac plexus directly, because look, it's right in front of the aorta. So the celiac plexus is an important area for our purposes. Both parasympathetic and sympathetic innervate that complex. This is the meat and potatoes. So here's a cross section of the vagus nerve. Now in red, that's the carotid sheath. Inside the carotid sheath flows artery, vein, and vagus nerve. Jugular vein, carotid artery, and vagus nerve. The carotid sheath, remember what I told you about the most electrically conductive. So you don't actually have to poke a hole into the carotid sheath to get electric into the vagus nerve. And we're going to actually practice stomach 9 on each other. I'm going to demo it first. But you'll notice that the force of insertion is very light. As soon as I feel resistance, that's it. I don't push any harder. I don't go into the carotid sheath. I only want to touch my needle to the carotid sheath because the carotid sheath is very electrically conductive and it's going to send electricity into the vagus nerve and probably into the carotid artery as well. So this is a cross section of the neck, and the needle is coming, if you could picture the center of this magnifying glass, in this direction. And our target is right here, but if you touch anywhere on the red carotid sheath, you'll be fine. You'll get the result. And then I drew out over here the path of the vagus nerve. So the protocol for rheumatoid arthritis is left stomach 9 and left stomach 11. And you can substitute 11 for this ear vagus point, which was in foundations class also. So you can, a little bit of variation, because if you're going to see them 3 times a week, you may want to alternate stomach 11 with ear vagus. The vagus nerve comes to the concha floor, and the closer you get to the ear canal, the more to the surface the vagus nerve comes. So that's why I highlighted in red the ear vagus point. So any questions about the location and what the target is for this left cervical vagus? You can leave it there. However, I don't know if I could sleep well at night because it's so close to the ear canal. I'd be scared of them pushing it in. So the answer is yes, but I don't feel comfortable doing it. But that's just a personal thing. because I don't want it to go, they may, oh, what's this itchy thing? And then they scratch it and push it in or something like that. So the real answer is yes, but I tend not to leave somebody with anything on the contrafloor or anything close to the ear canal. That's a good question. If you remember, I said no hard force, right? So if the patient is above 50, if you want to get real safe about it, you'll break out your stethoscope and you'll listen for that. But you don't have to, because above 50, you're not going to be pushing, feeling for the carotid artery. Just insert the needle and then take your hands off. You'll see me do it in a few minutes. Take your hands off, no force. You don't want to push into anything. You don't want to push into the artery there. You don't even want to push too much pressure here in case they have a blockage and can release that blockage. So there's no contraindication, but the older the patient, the more careful you are about pushing with your fingers to feel for the carotid pulse, which you don't need to do. I'm going to show you. It's exactly halfway between the Adam's apple and medial border of the SCM, so you don't even need to feel. Just lightly insert needle and hook up electric. This is a different view of our protocol here. Stomach 9, stomach 11 in between the two heads. Link this together and you're influencing the left cervical vagus. We said the left cervical vagus goes to the celiac plexus. Celiac plexus is actually our target. Thankfully, we can reach it from left cervical vagus. I'd like to practice on each other because there's no way anybody's leaving here this weekend without being able to be comfortable to needle stomach 9 on your patients. So the next part we're going to practice on each other, but I do want to demo it first. Does anybody want to be my patient for stomach 9? You want to? Sure. Okay. So I'm going to take a minute break and then I'm going to get him set up here. I'm going to demo this treatment on here. And then we're going to hopefully do it on each other somehow. You guys okay with that? Have you guys seen my devices, tips, and tricks video where I tell you to use a half-dead battery? I highly recommend it. So he has psoriatic arthritis, which is in the same category as rheumatoid arthritis. It's the same series of inflammatory cytokines that have gone haywire. So this is actually a good treatment for him. The protocol for rheumatoid and psoriatic arthritis are the same. So I forgot to put that in my slide, psoriatic arthritis. So just try to remember or make a note. It's the same as rheumatoid. I would. It's still worth treating. See if you can get their primary care to work with you or the rheumatologist to work with you to decrease the medicines over time and see how they're doing. The good thing is you can test for tumor necrosis factor in the blood. So that can be a marker. If they're reducing meds but the tumor necrosis factor is still staying low,
Then you what?
yeah. Chronic. This is for chronic and specifically a whole series of diseases that are under this category. It's divided by which cytokines you're trying to influence or which portion of the immune system. So for rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis, those are all in the same category.
How about just psoriasis?
Psoriasis, yes, same category. Ulcerative colitis, Crohn's, they're in this category.
Okay.
Tomorrow we're doing MS, and that's a whole different category. They're listed in there. Protocols listed in there. Divisions are listed in there. So this one is influencing the celiac ganglion, which is connected to the spleen to downregulate tumor necrosis factor and interleukin-1. The STE36 is more about a dopaminergic anti-inflammatory catecholaminergic pathway. So it's two different pathways, is basically what I want you to know. Halfway between the Adam's apple and the medial border of the SCM, you should feel a big space in there. Now I'm not pushing too hard. I'm just trying to feel the carotid, which I do very easily. And it shouldn't hurt. If it hurts, which is maybe 1 in 100, I remove the needle and I start again because it shouldn't hurt. This is slipping in like butter, and I'm going all the way straight back at this angle until I feel a little resistance. Now I know the tip of the needle's on the carotid.
How deep?
Sheath, not the carotid artery.
How deep are you?
You can come look, it's about 30 millimeter insertion. Use the way it feels to know when to stop. I'm going to walk around and help you guys because it's a very light insertion. Deep but light. And if you're in the space, it should go in real easy. That's stomach 9. These are 40 millimeters. I would have preferred a 30 millimeter. Use a blue sarin. They're for patient comfort. Stomach 11, you go much shallower. I go maybe only quarter sun or less.
Because it's closer to the surface?
Same angle, and because we don't need it deep there. We need something to link this with. This is what's doing all the work.
So it's not.
Kind of perpendicular to his neck.
Okay, but perpendicular would be kind of over.
If you went this angle, it would still be okay. For the SEM, just feel for the space. Go kind of shallow. That wasn't deep at all. If you're using an ETO, put black on stomach 9. So a rheumatoid patient, I'm rarely doing more than 4 needles. I do 2 needles for this, and then I do maybe 2 needles for a global analgesic. Because the fact that we're reducing tumor necrosis factor, the patient's problem's going to go away. I am worried, but I'm not too worried because it's very shallow insertion.
Right.
Yes, I would prefer 30 millimeter here and 15 millimeter here. Tell me when you just start to feel something, like a tingle. Okay, is it light, moderate, or heavy?
Light.
Okay, you can handle it?
Mm-hmm.
All right, does anybody want to guess what frequency I'm using? That what it feels like?
I have no idea. I'm guessing.
You want to guess? Not using one. It's a solid light with a half-dead battery.
10.
300.
I was just going to say.
Acetylcholine, remember? If you've tried a fast frequency in your clinic, you probably had your patient jump off the table. And that's because the machines suck. So the way we work around it is use a half-dead battery. Half-dead battery allows you to use a fast frequency and your patient won't jump off the table. Fibro is its own world. They're not recovering. There's no parasympathetic recovery. So that you could needle them and that micro trauma they'll still have 2 weeks later because there's no recovery cycling. So you have to fix the recovery cycle. And caffeine has a long half-life. I believe it's 6 hours, which means if I drink a 20 ounce of coffee at 8 a.m., by 8 p.m., 4 ounces of that coffee is circulating, or 4 ounces of caffeine worth is still circulating. Caffeine will let you go to sleep, but it won't let you go into deep restorative sleep. So if they're drinking coffee, get them off the coffee. You have to get them sleeping. That's it. I'm going to leave. You guys can look here, and then I want to somehow practice on each other, and I'll walk around and help you guys with stomach 9. If you guys can be comfortable with stomach 9 by the end of the weekend, that's huge. You're going to be able to help so many people in the optimal way. Yes, I'd go a little more medial to where you were, but you're pretty close. And you should feel a space in there. But don't push too hard because if you have a blockage in the carotid artery, you could release it. Thyroid can be related too for fibro. And even blood work shows up normal, they still may be hyper. So everything's light in this area. Light
Right here?
feels. If you're feeling the pulse, perfect. Aim right for the pulse.
Aim right for the pulse.
Yes, because that's the carotid sheath.
Okay.